Hello, everybody, and welcome to the 14th week. Wow, we're in week 14 already. With the 14th week of Introduction to Sociology, SOCI 111. My name is Matthew Howell. I am located at the Valparaiso campus. You can reach me at mhowell1, that's MHOWELL1, at ivytech.edu if you have any questions about anything we cover. Today we're going to be covering Chapter 19, Health and the Environment, I believe is the title of the chapter. Yep, Health and the Environment. How about that? I've actually got a memory. Anyway, some of the things we're going to be looking at in this chapter today. We'll be examining the sociological perspectives on health and illness. Taking a look at social epidemiology, which is tracking the spread of disease throughout a particular society. Taking a look at that in health. We'll examine the state of healthcare in the United States. We'll take a look at mental illness in the United States. We'll take a look at some sociological perspectives on the environment, and we'll have a little discussion of environmental concerns, environmental problems. And then we'll take a look at the social movement referred to as environmentalism and see how that interacts and influences policy. So, some of the questions we're going to be taking a look at. This is becoming more and more of an issue. What are the people who cannot afford to drink bottled water supposed to do? There are a number of issues with this particular environmental concern and health concern. Won't the environment eventually threaten everybody, no matter how much organic food they consume? That's a question we're going to try to discuss. And what defines a healthy environment? So, and how does healthcare vary between social classes and nations? All of these things play into the health of people throughout the world. Okay, sorry, I was just getting a drink there. Health can be defined as a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. This was a definition that a couple of researchers, Lavelle and Clark, came up with in 1965. This is also the definition of health used by the World Health Organization. This is how they define what it means to be healthy. And you can see that contained within that definition is the recognition that it's not just about physical and mental health. It's also about social well-being, being connected to a social group. Now, the next statement, health is socially constructed, and we can view it in a social context. Now, the idea behind health being socially constructed, what does it mean to be healthy? What does it mean to be sick? How sick is sick enough to call into work? All of this tends to be socially constructed. So we think about the idea of calling in sick to work. Those of you who might have worked a fast food job at one point in your lives, how welcoming are managers if you call up and you say, I've got a cold, so I'm carrying the rhinovirus, so I don't think it's a good idea if I should come in. Is that sick enough? Having the common cold, is that sick enough to call in sick to work? The interesting thing is, in the restaurant industry, it's not really. There are some changes. We're seeing some change happening about this. But really, it has not in the past been considered. I spent 20 years working in the restaurant industry, and I got in trouble from my supervisors for sending sick employees home. They say, well, you don't have enough people to staff your restaurant. And my response always was, well, I'm trying to keep my customers from getting the common cold. Because let's face it, that is something that is very contagious. But is it sick enough? Or can you call in sick because you've got cavities in your teeth? Technically, that is described as an illness. You're not healthy if your teeth have cavities. But is that something you call in sick for? So viewing in a social context, of course, that's what we're doing right now when we discuss these things. What constitutes being ill? What constitutes being well? Now, from the functionalist perspective, some of the things that we talked about, like how sick is sick enough to call into work? Well, the functionalist perspective says the state of being sick has to be regulated, because when you claim to be sick, one of the things that happens is, and this is based on the work of Talcott Parsons, you assume the rights and responsibilities of the sick role instead of that of a healthy person. And one of the things that happens, one of the first things that happens when you claim to be sick is you are excused from the majority of your societal responsibilities. You do not have to, you are not expected to maintain all the responsibilities you maintain when you're in a state of health. So this idea of the sick role is the societal expectations about attitudes and behaviors of a person viewed as being ill. So, thinking about this idea of the sick role, we've all probably employed this at one time or another. Have you ever been scheduled for a shift on a Friday night and thought, boy, I really wanted to go to that party? What do? We call up and we call in sick. Now, attitudes and behavior of a person viewed as being ill. What kind of behaviors are we expecting? Are we expecting them to sound robust, healthy, chipper, and cheerful? No. So when you call up and you're sick, don't you try to do the acting, and the Oscar goes to, boy, I'm just so sick that I'm not going to be able to make it in today. That's what may happen sometimes, and that gives us a good idea about what the sick role is. Now, many times you may be asked to provide a doctor's note if you're claiming to be sick. That's because physicians function as the gatekeepers, the people who decide how sick is sick enough to be excused. So when you get that doctor's note, it may say you're excused from Thursday, Wednesday and Thursday, but then you need to report back to work on Friday. So the doctor's in the doctor role, which is another idea that Talcott Parsons had. He saw the interplay between the sick role, the patient role, and the doctor role. Now, the sick role, some of the expectations you have is that as you return to a state of health, you will begin discarding the behaviors of the sick role and begin reassuming your societal responsibilities. And another addition onto that sick role in the form of the patient role is that you will work with the doctor and you will obey the doctor's orders in order to return to that state of health. And all of this was in Talcott Parsons' work examining medicine as a structure in society. Conflict looks at it a little differently. Conflict looks at what's referred to as the medicalization of society. 150 years ago, if you tried to claim that alcoholism was a disease, you'd get laughed out of everywhere because alcoholism was viewed as a weakness of willpower. Now, addiction has become medicalized as a condition, and there are more and more different types of addiction we're hearing about all the time. Not just alcohol and drug addiction. Some physicians are talking about the fact that we can become addicted to sugar. Some physicians believe we can become addicted to gambling because of the endorphins that get released, to pornography, to sex. All of these things are being claimed as addictions. Now, when we think about medicalization of a condition, one of the things that happens is as more and more conditions become medicalized, the influence of medicine as an institution expands throughout society, becomes part of regulation and social control within the society. The other thing it does is it restricts people who are qualified to treat particular conditions. If we believe that addiction is truly a medical condition, 12-step programs have no place in treatment, because that's about treating it like something that an individual can overcome. And once we medicalize a condition, what we're saying is people can't overcome these types of things without the help of a doctor. So it restricts the number of people that are allowed to treat particular afflictions. So we have a greatly expanded domain of expertise. Problems become viewed using a medical model. This leads to the devaluation of psychology as a therapy approach, what's referred to as talk therapy, because talk therapy in the past has had success. But once we create a condition whereby we're treating something as a medical condition, then we begin culturally to try to treat it with drugs as opposed to talk therapy. So talk therapy becomes devalued. Drugs become increasingly used to treat these problems. And so it allows the medical people to retain jurisdiction over health care. Anytime we're using drugs to treat a particular condition, we're not allowing other practitioners who might not be part of scientific medicine, such as chiropractic, such as I said, psychology, because the difference between psychology and psychiatry is psychiatrists are doctors that can prescribe drugs. Psychologists cannot prescribe drugs. They are counselors. And so it creates this situation where psychiatry has greater domain over the treatment of mental illness than psychology does, even though psychiatry has less training in the psychological sciences than a psychologist does. Another thing it looks at is inequality in access to health care. If you are part of the upper class in our society, the difference in access to health care means that people from the upper classes live an average of 7 years longer than the rest of the people in our society. That's based on unequal access. So there's glaring inequalities within health care. Now, brain drain is the condition created whereby individuals who would be more valuable in their own society come to the United States to, say, practice medicine in the context of healthcare, but lots of different applications with this. Skilled workers, professionals, and technicians that would create much more value in their own society. Think about it this way. Do you think that the nation of India has greater need for doctors, or the nation of the United States of America has a greater need for doctors? Most people would kind of agree that India really does need more doctors. They have a larger population. They do not have the standard of living as far as sanitation, personal hygiene that we do here in the United States of America. And so every doctor that leaves India to come practice medicine in the United States of America would be much more valued in India. And this is a condition called brain drain, where those people are kind of skimmed off and brought to live in the United States of America. On a global scale, that should say dramatic differences in infant mortality rate, not infant morality rate. Really, infants are too young to have developed morals yet to have a moral base. So it should say mortality. And the number of deaths of infants between 0 and 12 months of age per 1,000 live births in any year. The United States of America, our infant mortality rate is roughly 6.1. So on an annual basis, of every 1,000 babies that are born, 6.1 of them die before their first year is up. Now, in low-income nations, this number can be as low as 19, but it can go as high as 31. That's a 13% infant mortality rate. If 131 out of every 1,000 live births are dying before their first year is out. That's a 13% infant mortality rate. That's incredibly high. Okay, the interactionist approach. It looks at how those roles we talked about, the sick role, the patient role, the doctor role. Interactionist approach looks at how those roles shape interaction within the field of healthcare. So they study the roles that are used by doctors and by patients. Doctors tend to be very authoritarian. They tend to believe that they have all the answers. Many people talk about what's referred to as the God complex that develops among doctors because they have life and death in their hands. They tend to overvalue their opinion in any particular setting. And so this is one way in which their profession kind of shapes their interaction with the people around them. But we can also look at how this shapes interaction. The ultimate authority in any course of treatment is the patient. The patient is the one who makes the ultimate decision on whether to accept or reject any suggested course of treatment that the doctors may lay out. Yet we tend to revere doctors in our society, and how many patients actually go to get the second opinion for maybe serious things, but minor things, usually we just tend to rely on whatever doctor we have. Unfortunately, somewhere out there in the country is the worst doctor in the United States of America practicing medicine somewhere. Going and getting a second opinion mitigates the different level of skill between doctors. But because of that authoritarian role, many patients accept what the doctors say without verification. And this is best examined from the interactionist approach because of the meanings we assign to the roles that we're playing. The other thing that the interactionist, as I said, if you're active or passive in your course of treatment, this may have positive or negative benefits with regards to health. If we have an active role in taking care of ourselves, this may play out in being more willing to engage in preventative medicine instead of just curative medicine. And the difference there is preventative medicine are the things we do like exercise, eating right, that are designed to kind of create good health. Curative medicine is what we do once we are afflicted with an illness or a condition and we go to seek the doctor. But yeah, essentially, interactionists are looking at how active or passive the patient is in the interaction between doctor and patient. Of course, one of the branches of interactionism, we were looking at roles there, and kind of like if we think about Irving Goffman's dramaturgical analysis, the doctors use props, they create set, they have scripts and all this other kind of stuff. I mean, the set, think about it. When you go into the waiting room, who's waiting for who? This sets up the nature of the authority in that relationship. Patients wait for doctors. Doctors don't wait for patients. That's why most clinics have what's called the waiting room. It's where you wait to be seen. Labeling approach looks at it a little bit differently. It's still looking at the meanings attached, but instead of focusing on the roles and the meanings of the behaviors in the roles, labeling approach focuses on the idea of what does it mean to be healthy, what does it mean to be ill, and how does each society define that? As I was discussing in the early part here, when we think about calling in sick to work, how sick is sick enough to call in sick to work? Is having a cold sick enough to call in sick to work? Is having a headache sick enough to call in sick to work? This gets socially defined for us, the idea of what it means to be healthy and what it means to be ill. 80% of our population suffers from a particular affliction, but rarely would people call in sick for this particular affliction. And it's another one I referred to earlier. The state of having cavities in your teeth, technically that's ill health, But how many of us would think about calling in sick to work because we were told by our dentist the day before we had a cavity, oh, and now we can't go into work or go to school until we get that cavity fixed and filled. And that might be a week away since the dentist didn't have an appointment. You get the idea behind what I'm talking about here. You can't just claim the label of ill. Society has to agree to that according to labeling theory. The example they provide here, of course, homosexuality up until the 70s was defined as a mental aberration, almost like an illness. Following some reforms, the American Psychiatric Association, the American Psychological Association, and the American Medical Association, beginning in the 70s and then moving into the 80s, increasingly defined homosexuality not as an illness, but just as an orientation. They took the stigma, tried to take the medical stigma out of that particular condition. But if you go back 100 years, homosexuality would have been almost defined as a mental illness in our country. And so we see here a case where something that was defined, was kind of medicalized and defined as an illness, be removed from that list, and is not any longer considered a mental illness or a mental aberration. So when we think about all these kind of life experiences, are they illnesses or not? What constitutes being ill? Addiction. Can we get addicted to drugs? Well, there's physiological evidence that yes, we can get addicted to drugs and alcohol. Can we get addicted to gambling? Can we get addicted to sex? Can we get addicted to pornography? Again, labeling approach would look at the idea of the social definition. Are these things accepted? Recently, gambling has really kind of been accepted as an addiction. There is some resistance to being able to define addiction to sex and addiction to pornography as medical conditions. And what we're talking about, of course, is this idea of social epidemiology, which is the study of how health and disease are distributed throughout a society. If you've seen the movie and the band played on, it was released in 1983, and I know that I'm really, really dating myself by referencing a movie that came out the year I graduated from high school. But the interesting thing about that movie is that movie looked at the group of researchers who were tracking the original spread of AIDS in our country, HIV and AIDS in our country, and had traced it all the way back to patient 0. Initially, they had no idea what was causing this, but there was a sociologist who specialized in the field of social epidemiology on that team, and he was the first one to kind of notice that when you put all the connecting up, it looked like a spread of a sexually transmitted disease. And that's what actually enabled them to begin to view HIV and AIDS as a blood-borne pathogen. Prior to that, it was referred to as gay cancer, and they weren't sure how it spread at all. So social epidemiology can play an important part in identifying how and why new diseases may be spreading throughout a society. So we've got two different kind of ideas with social epidemiology. The incidence, which is number of new cases within a particular population within a year, and prevalence, which is the number of cases that exist at any given time. So we may have an incidence of new cases of HIV at maybe 3,000 per year, but prevalence in our society, there may be 100,000 people living with HIV. So that's how the difference is. Incidence of new cases per year, prevalence is any number of cases at any specific time. And then we also have to look at morbidity rates, which is how many. This is converting it into kind of a comparable number, like a percentage or something like that. How many people have this particular disease per 100,000 people in your society. And then mortality rate would be the rate at which the disease kills people. So all of these are how we can look at the way that health and disease spread throughout society, and all of these are terms that are used in the field of social epidemiology. I mentioned this, being upper class means you have an average of 7 years longer in lifespan, and your quality of life extends out much later. When we talk about quality of life, that's being able to do things. If you ever heard somebody talk about, like, well, 60 is the new 40, what they're really saying is that the quality of life people experience at 60 now is similar to the quality of life people experienced at 40 a number of years ago. So when you hear people making that particular reference, what they're talking about is the quality of life. People in lower classes have higher rates of mortality and disability. If we think about something, there's a particular condition referred to as sciatica, C-O-I-A, and it's based on the sciatic nerve, which is the nerve that goes out to the legs from the spine. Sciatica is actually caused by compression on the nerve by the bones of the spine when a disc becomes slipped, becomes herniated, punctured, whatever. When you see people limping and using canes and using walkers, chances are they're suffering this spinal compression condition, but they don't have access to health care to alleviate it. So that's one way in which disability might be more prevalent amongst the lower classes, whereas people in the upper classes have the ability to get that particular condition treated through access to health care. And the effects are cumulative. Research has demonstrated that it appears cumulative. So if you suddenly become upper class by winning the lottery at age 50, that doesn't necessarily mean that you're going to enjoy all the benefits of health care that are available to upper class people, because you already have the first 50 years of your life where you may not have enjoyed that kind of access. So when it says it appears to be cumulative, the longer you have access to quality health care, your overall health is going to be higher at particular ages. Within our society, we are on the verge of establishing at least universal access to health care with the Affordable Care Act. Despite that, that doesn't mean that every treatment that's available in this country is going to be available to people who pay with insurance, because the more economic capital you have, the better you are able to afford the highest quality health care available in our country. And there's a link between health and economic mobility when we talk like social mobility, moving up and down in jobs. Now, most people assume that being lower class is what leads to poorer health outcomes. But there are some researchers out there that flip that on its head and say, well, if you have poorer health and you have to take more days off from work, and you're what they refer to as a sickly person, this can affect your economic mobility. So the only kind of economic mobility you have is downward. And this would be a case where the causal pathway is believed to be the reverse of what most people assume the causal pathway with health and economic class, being that class determines health instead of health determining class. Just wanted to point out there are some researchers out there that believe there's a link that demonstrates that health can actually poor health can contribute to lower class outcomes, lower economic outcomes. Race and ethnicity play into this. Amongst African American communities, the infant mortality rate is almost double that of what it is amongst white communities. So if we say it's 6.1, that means it's roughly 12 or over in African American communities. And so some of this happens because of the correlation between minority status and living in poverty. but that doesn't explain everything. But when we look at that link, we do see that economic and environmental conditions manifest in high morbidity and mortality rates. There's a documentary called The World According to Monsanto. And in this documentary, there's actually investigation of what's referred to as a cancer cluster. Cancer clusters are usually occur in low-income neighborhoods, and what it is where this particular neighborhood has a cancer rate, a particular cancer rate that is much, much higher than the national average in surrounding neighborhoods. A lot of people tie that environmentally into this idea of environmental injustice, where pollution is centered in lower-income communities. In the documentary I was referring to, The World According to Monsanto, that is the claim of the documentary makers, is that this cancer cluster exists because Monsanto is continuously dumping toxic waste into the surface water system near this small town. African Americans have higher death rates, they have a lower lifespan expectancy, and they have higher infant mortality rates as well. Mexican Americans, especially Mexican Americans, first generation or second generation immigrants, may resort more to curanderismo, or curanderismo, which is folk medicine of a type. It's a form of holistic care and healing. So you may see that more prevalent amongst Mexican American communities. Women tend to live an average of 5 years longer than men in our culture. There is no consensus on why this happens. Some researchers feel that it's because work is actually a very stressful thing in our post-industrial society, and so men are suffering much higher rates of stress as they are the ones that participate in the economy more. And that as we see a switch where women are increasingly reaching equality, or may even in some fields there may be more women than men working, they're beginning to look at it as kind of an environmental thing. Women may begin to experience stress-related conditions as they increasingly participate in the economy. Women experience a higher prevalence of many illnesses but tend to live longer. They have a lower rate of cigarette smoking. Women tend to consume less alcohol and consume it less frequently. The high-stress occupations, women are not employed in as great numbers as men are. Like if you look at Wall Street, it tends to be overwhelmingly male. That tends to be very, very high stress. Working with finances generally tends to be stressful. Women may also go to see the doctor more frequently because of the socialized differences in gender role expectations. Men are expected to suck it up and just shake it off and that kind of stuff, and I can't tell you how many times I heard that while I was participating in athletics. Women are more socialized because of the fact that they bear the children. They're more socialized to seek treatment on a more frequent basis than men are. Age, of course. The fact that our society is getting older, and I want to say within the next few years, the average age in our society is expected to top 40 years. I think, in fact, it might have already. I think it might be 41 at this point in time. But most older people in the U.S. have at least one chronic illness. Now, the difference between acute illness and chronic illness are acute illnesses are sudden onset illnesses. You get sick quickly, and then once you get cured, you kind of get back to being healthy fairly quickly with acute illnesses. Chronic illnesses are ones that develop over the course of many, many years. And they're also the types of illnesses that it may take many, many years to alleviate the effects of. If you spend 20 years smoking, you can't just quit smoking one day and expect to have perfectly healthy lungs again. So chronic illnesses can also be referred to as like lifestyle illnesses to a certain extent when we think about cholesterol, a sedentary lifestyle, high-fat diet, these kind of things. But then we tend to also look at, or we tend to get certain types of senile dementia, Alzheimer's. These generally, Parkinson's disease, are late onset types of neurological disorders. So older people tend to be more vulnerable to these types of mental health problems. As we age, of course, we rely more and more on healthcare and healthcare practitioners to keep us in a state of health. So as a corollary, older people use more health services than younger people. I mean, that was the whole idea behind HMOs, is that you need everybody participating and paying into an HMO. And in a certain sense, it's the younger population actually financing the level of care that the older population needs, because younger people pay in to the insurance pool but don't make withdrawals in the form of treatment as frequently as older people do. Healthcare costs have skyrocketed. The entire impetus behind the Affordable Care Act was an attempt to kind of stabilize that and reduce it. It has, in a certain sense, begun to reduce costs. But you got to remember, all the Affordable Health Care Act provides is insurance. It gives everybody access to health care insurance. It's not actually socialized medicine. It's more like socialized insurance. And with the public option eliminated, that's where most of the problems came from. The public option would have essentially made Medicare available to everybody in the country if they didn't have access to insurance through another path. But if you look at these figures here, in 2000, the U.S. spent on health care an amount that equaled the money spent on education, defense, prison, farm subsidies, food stamps, and foreign aid combined. And I really have to say that that's discretionary spending on defense. Because every year a third of the federal budget goes to defense spending, and that's non-discretionary. So, but healthcare costs up there. They have started to at least stabilize to the point where they're not increasing as quickly as they had in the past. Okay. The AMA began the process of what we could call credentialism, requiring their programs of education and licensing to be the only programs that produce graduates able to practice medicine before the middle of the 19th century. So the popular health movement of the 1830s and 1840s is when the AMA began restricting the practice of medicine to only people who had MDs and DOs. An MD is a medical doctor, of course. DO is a doctor of osteopathy. There were a number of medical practices. Chiropractic was one of them, acupuncture, acupressure, phrenology, a lot of what you refer to as snake oil salesmen selling those are the people that would sell the curatives in the bottles, which were primarily alcohol. And the AMA got all of them excluded from the practice of medicine because they were unwilling to implement what we might refer to as scientific medicine, the application of science to the practice of medicine. And that's what the AMA really did more than anything else. They said you have to be educated this way, you have to understand that we use medicine in a scientific fashion, and if you don't, you're not going to get a license to practice medicine. So by the 1920s, physicians were really the ones, the doctors were really the ones that were in control of healthcare in this country. They controlled the technology in hospitals. They regulated who could do what, the division of labor of health personnel, and other health professions. Doctors were put in control of nursing and, a lot of other health practices. We think about it, psychology was becoming prevalent in the 1920s, but psychiatry was a branch that developed during this time, because this was essentially doctors who trained for a year as a psychologist in order to treat mental illnesses from a medical perspective rather than from a counseling perspective. Physicians are at the top of the pecking order. They have that position of authority with patients and nurses. Honestly, nurses are the ones that should have the authority with regards to prescription, because they're the ones that are around when people take medicine all the time. They're the ones that see the side effects, and they're the ones that understand the consequences of over or under prescribing. I mean, think about when you stay in the hospital. Who do you see the most? You see the nurses the most. You don't see the doctor. You're lucky if you see him 20 minutes a day, right? Maybe twice a day. But yeah, they have the position of dominance, the position of authority, and all of that began with the AMA and their drive for licensing and credentialism. This leads to a little dehumanizing physician-patient encounters. I mean, if you think about it, the first thing they do, we go back to that interactionist perspective, the first thing they do is they strip you out of your normal costume, which would be the clothes you wear, and they put you into a little paper gown. How dehumanizing is that? Just something to think about. And then, of course, really beginning kind of in the 60s and 70s, publicity about malpractice suits and high medical costs further kind of harmed the relationship between physicians and patients. Controlled interactions with nurses. Nurses in the 50s and 60s would frequently have to suffer just being berated and harassed by physicians. Now, that was kind of the norm in this country, unfortunately, in most of the professions. But yeah, nurses have had a long fight to regain some of the authority they had prior to the establishment of the AMA. One of the results of that is the creation of what's called the nurse practitioner, as somebody who can prescribe medicine and do things beyond things that are actually had historically since the 1830s and 1840s been restricted to doctors. We've all kind of become armchair physicians. We've got WebMD and a number of other websites. This harms some of the authority of the doctors, because when the doctors talk about a particular treatment, patients may have read up on that and they may say, you know what, I don't think that's the one for me. Because patients can turn to the media for healthcare information between websites like I mentioned, WebMD and other sites like that, but also think about how many shows there are with doctors dispensing advice. Just recently, Dr. Oz has come under fire for seeming to endorse some not medically approved treatments that would be kind of like homeopathic treatments or something like that, but treatments that are not recognized by the AMA as effective treatments. But when you watch Dr. Oz, you get, the idea that you're getting good, solid information from a medical professional that you can use in lieu of going to see the doctor. Alternative to traditional healthcare. There's all kinds of these things. And they're not just practiced by people at the fringes. These have kind of wormed their way into mainstream. Something like airborne, which is the one that advertises itself as the boost to your immune system to fight off the common cold. And airborne is sold as a medical treatment to help you fight off the common cold, but it was developed by somebody with no expertise in medicine at all. It was developed by an elementary school teacher who had no training in medicine at all. There are other things, I mean, from some that, like alternative healthcare, chiropractic, which has kind of come back into the mainstream of healthcare. It's had to fight its way back, but was considered alternative, or acupuncture, acupressure. These are alternative healthcare techniques. Even crystal healing, the idea that crystals carry vibrations that you can use to heal parts of your body. There's a number of people that subscribe to that as well. There's a different way of practicing medicine. This tends to be more Asian in philosophical approach, and it's referred to as holistic medicine. But it's looking at the individual as a whole. That's what the holistic is. It's looking at the individual as a whole and not just trying to diagnose and treat specific parts. Holistic medicine looks at the entirety of a person and tries to treat it from the perspective of, I'm treating the entire organism. I'm not just treating the virus that you acquired or something like that. So, how does government play into this? Well, we've discussed a little bit of this already with the idea of the Affordable Care Act. Medicare, Medicaid are government programs as well. In 1946, the government began a policy program of attempting to provide hospitals in all areas, to the point where every county had kind of its county hospital. This was a way that they provided health care out in rural areas. So this began following World War II in 1946. Kind of looking at the time at what England was doing, because it was following World War II that England decided, we're going to provide universal health care for everybody in our country. If you're an English citizen, you're going to get health care. The United States was following along with a little bit of that, kind of diverged a little bit. It was in 1965 that Medicare and Medicaid were established. And then I want to say 1971, when the first HMOs, health maintenance organizations, were established. Medicare and Medicaid are socialized insurance programs. It's not socialized medicine because doctors don't work directly for the government. What it is Medicare and Medicaid, the government provides the payment to the doctor for services rendered. And so, as I said, it's more along the lines of socialized insurance, medical insurance, than it is socialized medicine. Socialized medicine is more like what they have in Canada, where you go in and you show an ID and they take care of everything for you, or what they have in England, where the doctors are working more directly for the government. Now, that doesn't mean they're not making good livings. I want to say doctors in England start at somewhere around £70,000 a year, which is roughly $140,000 a year. So they're not paupers by any stretch of the imagination. They're not making as much as doctors in the U.S. are, but then they don't have to carry the massive insurance premiums that doctors in the U.S. have to carry either. Anyway, but Medicare and Medicaid, and then Blue Cross and Blue Shield were originally government-provided medical insurance. Anthem, what we have here in Indiana, was originally a state-run insurance program. And then those eventually got privatized. They eliminated Medicare for everybody except the elderly, and they eliminated Medicaid for everybody except the poverty-stricken. 1983, government instituted the cost control program, and this is where doctors actually began to be rewarded by HMOs for the amount of money they saved instead of the number of services they provided, which is a little bit backwards if you think about it. In our current, like in the HMO system prior to the revamping of it under the Affordable Care Act, doctors would actually get bonuses based upon not providing treatment. This seems a little counterintuitive. You know, in England, doctors actually make more money. They get their base salary, but they make more money based upon how many people they actually do treat. Here in the United States of America, the insurance companies pay doctors bonuses based upon the amount of treatments they deny. How much of that pool of money they manage to save. So that becomes problematic when we're thinking about the health of individuals in our society, because doctors are being rewarded for not providing care instead of being rewarded for providing care. Even from a functionalist perspective, that begins to create dysfunction in society, because more and more people wait until the situation is much more serious before they go to the emergency room seeking care because they can't afford it. Anyway, moving on now. Mental illness, it should say mental illness again. The top height is right, mental illness in the United States. Medical illness is any illness that disrupts the normal health and functioning of the body. It should say mental illness. It's a disorder of the brain that disrupts a person's thinking, feeling, and ability to interact with others. And there are all different kinds of them. If you've taken a psychology course, the DSM-5, which just recently came out, is what psychologists use to diagnose mental illnesses. However, in the 1960s, certain mental illnesses were sort of what they called mainstreamed. It used to be that schizophrenia would institutionalize. Somebody with schizophrenia could be institutionalized. That's no longer the case. That's one of those things that should be, they consider treating while the person's part of the general population instead of separating them aside. When Bellevue closed in New York in the 60s, the homeless population almost doubled, because these were people that were being told, well, you need to take care of yourself, but didn't have the mental capacity to do it. When we talk about detection, it's hard to diagnose. There's so much variation in the way that mental illnesses present. So a lot of time officials are poorly prepared to detect mental health issues. A lot of insurance doesn't cover this kind of stuff. So there's a limit to the availability of mental health services. Saying I suffer from a mental illness opens you up to a stigmatized condition. People do not want to openly acknowledge the fact that they suffer from a mental illness. And a lot of the stigma originated from the fact that when somebody claims to be sick, we expect them to exhibit the behaviors of the sick role. For people claiming mental illness, they're not really exhibiting the appropriate behaviors of the sick role. And so a lot of times mental illness is stigmatized because people don't give it the credence they do physical illnesses. So we got the medical model. Mental illness is rooted in biological causes that can be treated through medical intervention. This is like when you're using beta blockers to treat certain mental aberrations. They used to use lithium to do that. They use all kinds of things. But this is where you're using a lot of times medications to try and restore, to try and eliminate the imbalance. Labeling theory, when we think about this, mental illness is not necessarily an illness. It's really the way the society defines certain types of aberrant behavior as mental illnesses. So the individual's problems arise from living in society. You know, depression is defined kind of as a mental illness, And some researchers are looking at what they call an epidemic of depression, but they believe that it may have a lot to do with feeling alienated and disenfranchised in our society rather than a chemical imbalance in the brain. But when we think about the medical treatments that have been very effective, oftentimes labeling theory devalues mentally ill patients by saying it's not necessarily that they need treatment, it's just that they're living in society. So that becomes problematic. When we think about it, mental illness, another reason it's stigmatized is because it hasn't always been referred to as mental illness. Think about addiction. Addiction has become medicalized and is viewed as an illness that needs to be treated, and in a lot of ways it's a mental illness, since it's almost like a dopamine addiction. You begin to crave the dopamine released by certain activities. But it used to be viewed as a lack of willpower. And then even before that, if you couldn't quit drinking, it's because the devil had a hold of you and you were possessed. So when we think about possession, the religious influence on the definition of mental illness that dates back the idea of possession is another reason why it remains stigmatized. But it's been a concern of the government longer than physical illness. And the reason for that is that most physical illnesses, up until we went through the Industrial Revolution, were acute and not chronic illnesses. It wasn't until lifespans extended beyond 35 and really doubled that we begin to see more and more chronic illnesses, heart disease, these kind of things, high blood pressure. So mental illness has been a government concern longer than physical illness. There were lots of what they called asylums, and these were where, going back 100 years or more, mentally ill people were confined, what they call insane, the public institutions. In 1963, the Community Mental Health Center Act increased federal government involvement in the treatment of mental illnesses. This is when we began to see a lot more institutions created for housing people who simply couldn't care for themselves. It also made it easier to commit mentally ill homeless involuntarily, because oftentimes they would not want to seek treatment themselves, or couldn't seek treatment themselves. They just didn't have the mental capacity to do it. But this way the government could say, for the protection of this individual and other individuals, we're going to commit them and they're going to be cared for. They're going to have food and shelter and everything else. But then in the 70s and 80s, a lot of these people were released back out into the streets as the funding got cut off for some of these institutions. Moving on to the environment now. The environment is what surrounds us. So the environment in which we live has an effect on our health. Look at what's going on with living in Beijing now, and air quality. A lot of that has to do with industrial production. So increases in population together with economic development have serious environmental consequences. The air quality in Los Angeles Basin gets so bad sometimes that it can really affect young children and the elderly. It's not as bad as it is in Beijing. The reasons are very similar, but Beijing is just, sometimes it is so dense there that it is like trying to walk through a cloud, but it's smoke, and toxic smoke at that. So human ecology is the interaction between human beings and their living environment. Urban ecology, as a branch of human ecology, looks at the interactions of people living in an urban environment and how they interact with their environment. But when we think about human ecology, there's a few things going on right now that are very controversial. One of them is the idea of climate change. If we don't pay attention to climate change, we'll start losing, as the seas flood, we'll start losing land. But if we implement draconian environmental controls to mitigate climate change, then we're going to see a lot of people suffer. So human ecology is the trade-off between making sure that people are taken care of, but at the same time making sure that the environment's taken care of. So when we talk about carbon reduction, you know, it sounds good, but there may be a cost in human suffering for reducing our carbon footprint by 30%, because there's not going to be as much power produced, and the other types of power we have can produce great amounts of power, but they aren't quite as reliable as burning coal and burning fuel. And that's where this trade-off comes. How do our policymakers, you know, the people who are worried about the environment versus the people who are worried about our economy and our ability to produce in our economy, we have to figure out how to continue production, but at the same time, how to preserve the environment. So, when we look at conflict view of the environment, not the environmental, the environment, what we're seeing here, this idea of resources of developing countries redistributed to core industrialized nations, that comes out of Emanuel Wallerstein's World Systems Analysis. And it's the idea that low-income nations are exploited for resources by high-income nations. Ecological modernization is this idea that when we do develop new technologies and stuff like that, we need to align environmentally favorable practices with economic self-interest. Interface Carpet is one that is a business trying to do ecological modernization. They and their CEO, who I believe is a man named Ray Johnston, they are trying to restructure their economic production to reduce their footprint, their carbon footprint, to zero by 2030. Which is a strong goal. But what they're basically saying is that if we want to continue to produce this product, we need to figure out a way to do it in an environmentally favorable way. And I mentioned environmental injustice. Well, environmental justice is the idea that we need to protect the environment equally for everybody. And the idea behind environmental injustice is that racial minorities are disproportionately subject to environmental hazards. If companies trying to dump toxic waste, chances are they're trying to do it in a low-income neighborhood where people have less education and less resources to fight that. And when we bring race into that, because poverty status correlates with minority status, we get this idea that minority groups are disproportionately subject to toxic waste hazards and other environmental hazards. So, what are we looking at here? Air pollution, water pollution, and global warming. Those are the three big areas of concern that people have. And air pollution, because it actually contributes to global warming. The more carbon we have in the atmosphere, the more heat we trap in because of that. Global warming, climate change, controversial, but really 90% of the scientific community agrees both that the environment is changing, is getting warmer, the climate is getting warmer, and that human activity is accelerating that. Over 90% of the scientific community believes that human activity is accelerating climate change, and that climate change is occurring more drastically than it ever has. But when we think about globalization, industrialization, of course, increased pollution, and the more countries we have going through the industrial transition, the more pollution we have pumping out into the atmosphere. Multinational corporations have incentives to carefully consider cost of natural resources. There is an individual who believes that the best way to protect clean water is to completely privatize it. It says once somebody has an owning interest in that, then they want to protect that. Of course, that part of it may be true, but the other thing is then people, are denied access to it. Like right all the way at the beginning of this particular, where are people going to get drinking water? Environmental refugees, people who have to leave certain areas because of environmental disasters. So this is a reflection of interplay between globalization and the environment. And this goes back to people having to leave the ever-ready, when the battery plant melted down in India in the 80s and people have to leave that area. They become environmental refugees because they're displaced from their home because of environmental issues. So when we think about environmentalism, if you've heard of Earth Day, the first one was in 1970, and the idea behind Earth Day was that we were going to create policies favorable to environmental conservation. Air pollution, water pollution, these were some specific environmental causes. At the same time, Congress established the EPA, the Environmental Protection Agency, which is the governmental agency responsible for reducing industrial pollution. And then we had Clean Air, Clean Water, and Endangered Species Acts. And the Endangered Species Act has actually prevented development in some areas because species, that's the only place they exist. This was played out in Arizona with regards to like the red squirrels and on Mount Graham, preventing development of a new observatory there. Clean air and clean water. What these have is essentially like standards for pollution, that you can't pollute more than a certain amount, and if you do, then you have to pay what's called a carbon tax to the government. So essentially a fine for polluting more. The problem with some of that is that it becomes more profitable for companies just to continue paying the fine because it's so expensive to upgrade to reduce the emissions. So Earth Day is now fairly recognized to the point where city councils, zoos, and museums worldwide may hold celebrations of, and not every single one, but a lot of them hold celebrations of Earth Day. A lot of advocacy has moved on to the internet. Well, we discussed that when we talked about political participation, and one of the ways that we've, environmental activists reach people is through the internet. The League of Conservation Voters, they are people devoted to environmental concerns, and they examine voting records and send out emails and stuff like that. The Sierra Club, a lot of these groups reach people through the email and through internet. Because there's been a lot of debate over how much damage we're doing and how can we be doing this damage, and the fact that we're a very strongly religious nation, much more so than the secular nations of Europe, the general public has mixed reaction to environmental issues, and I can think of a couple political quotes, where this religious basis plays into this, because if you believe that in creationism, you're going to be less favorable to environmental conditions because the religious foundation is essentially that how can man destroy something that God created? It just can't be done. This may play into it. Some of the other ones are, well, yes, it would be great if I didn't need to drive every day to get to work, but we don't have a public transportation infrastructure that allows a lot of people to do that. You live in LA, you have to have a car to work, or you have to work next door to where you live, kind of thing. Because LA doesn't really have great public transit. And so some of these may contribute to the reasons why. And then the largest organizations are suffering from what's referred to as institutional isomorphism, where the bureaucracy comes to dominate everything else within those organizations. So, conflict theory and feminism would look at the whole idea of environmentalism and say that what's really troubling about this is that the people who are in control of these environmental organizations are white males, affluent males, and they may not share the concerns of everybody else in a particular society. That would be a conflict and feminist perspective. Moving on with more of this, the idea environmental organizations need operating capital. And so how do you reconcile getting money from BP when you're all about preserving the Gulf of Mexico? That's just one idea there. And then research can be biased as well, because if you're doing research and you're getting funding from oil and chemical companies, they may want you to suppress any findings that call into question the idea of continuing to use oil or chemicals, particular chemicals. And so this can be a conflict of interest. And then there are people who are just resistant to the environmental movement, and the environmental movement aroused resistance because the strident way in which they go about presenting their message sometimes. Okay, so when we think about policy, well, 2008, the country went into the toilet, pardon my language. It really... we had a huge economic downturn. Unemployment skyrocketed in this country. It was like close to 10% nationally, which is very high for us. But it actually reduced emissions because it reduced the use of fossil fuels. And some of the jobs program, there were funds established by the federal government for creating what are referred to as green-collar jobs, jobs within the environmental industry. And then environmentalism, I mean, think about how big an issue that was in the 2012 election. Wind power, the wind turbines, trying to figure out how we're going to create solar power and wind power. So environmentalism moved on to a bigger stage. And there's a generational effect going on, but overall, most people are beginning to believe that environmental issues should be one of the more important issues in the next presidential campaign. Younger people much more so, older people less so. And a lot of that has to do with, well, I mean, I grew up in the 50s and we didn't pollute the planet too much then, so I don't see how it's any different now. It's not really different, but what's different is the knowledge we have about that pollution. And so that may play into that cohort effect. Okay, that concludes our discussion for today of Chapter 19. We will have another one of these next Monday, but we've only got 2 more of these to go. Next Monday we'll be covering Chapter 20, and I believe the following Monday will be 21 and 22. Chapter 20 is population and urban lifestyle. Chapter 21 is social movements and social change, collective behavior. or Chapter 21 is collective behavior and social movements, and then Chapter 22 is social change. So have a good week, and we will, I will have another lecture for next Monday at this time.